Dr. Stanbuck did a lot of nice work for me, which maybe we can even use some of that in this. I'm going to go over a few things about nasopharynx cancer. I want to thank the organizers of the conference, and particularly Dr. Ridge, for inviting me to speak on such a esteemed panel.
Worked for everybody else.
Oh, yeah. Jonathan said, it worked for everybody else.
Could we have lost the battery? No?
Can I advance manually off of that?
Sir?
Is this
No, this is the one.
I can just call it in.
Okay, I think we've done it.
Oh, yeah?
Have
Okay.
you done that, or did we? Okay.
Okay. Oh, yeah, we're doing it. Okay. My disclosures, I receive research support from a number of entities. I also receive a honorarium from Astra for being a journal editor and a royalty for a book chapter. So nasopharyngeal cancer, it's very interesting to me. We have a close relationship to it in the Bay Area where I come from and I work. It's a very common disease in southern China and Hong Kong, as many of you might already know, and it accounts actually up to 18% of all cancer diagnoses, is the number one killer of men in the mid-range of age in some of these countries, and actually there are entire departments devoted to nasopharynx cancer in certain areas of southern China, and it's actually been called the Cantonese cancer because of this predominance in that population. But it's also common in areas of outmigration from the Cantonese regions, areas like Taiwan, Singapore, Malaysia, Thailand, and Vietnam, and in fact the very highest incidence in the entire world is in Malaysia. It's also seen in other places where there was an original landmass together, Africa, the Mediterranean, the Alaskan Inuit, and as you can see here, when we were all one, nasopharynx cancer sort of started in this area, and it's just been a spread outwards from what we now see as the endemic region. But as you saw on that chart there, it's very uncommon in the United States. Nonetheless, I will say there's a couple things we can say about it that hold true across Asia and the United States. They tend to be male predominance for this disease. They tend to be younger patients than most other head and neck cancer sites. So, for instance, in our database at UCSF, we have probably a good 20 or 30 patients who are younger than 15. About 20% overall of these patients can be younger than 30, and there's a little bit of a bimodal distribution in my experience where you can see them very young and you can also see them older. The median age is 55, which is a bit younger than other head and neck cancer patients. And as you can see here, there's certainly an ethnic factor in this disease. You look at the rates across Hong Kong and Singapore, and then look at places where there have been large traditional Chinese migrations or Chinatown establishments like San Francisco, and our rates are almost similar in some respects to those among the Chinese population, but then again, the very dramatic difference looking at other ethnicities in comparison. And what's interesting about this to me is that this actually holds up across generations, further lending epidemiologic support to the idea that there is a genetic or ethnic component to this disease. Even in second-generation Chinese males, when compared to similar white male counterparts, the rates will still be much more elevated in that population. So nasopharynx cancer, I always tell my residents it presents with nose, neck, and ear. You're going to have probably the most common symptom being the neck mass, but other symptoms include obviously obstruction of the nasal areas or bleeding. Some of our patients report a lot of discharge or quote-unquote allergic symptoms. They can also have ear symptoms with plugging of the ear from the pressure and retained fluid. And then more advanced cancers can manifest with cranial nerve involvement, orbital invasion, proptosis, and trismus when they get very advanced. And the workup is pretty standard. It's similar to other head and neck cancers. You do the head and neck exam. You need a biopsy of some kind. We like to get a biopsy from the primary, but you can also do it with an FNA from the neck. You need some imaging. Dr. Stanbuck reviewed really nicely the differences between MRI and CT. I will say MRI is pretty much de rigueur for nasopharynx cancers. In fact, most sinonasal cancers at our institution, but certainly some people believe in CT to assess bone involvement. PET-CT is often used for staging now, although again, I think bone scan and chest x-ray are reasonable in resource-limited institutions. And EBV titers, while it is mentioned in the NCCN guidelines, is not necessarily a requirement, because we'll talk about that a little bit, but standardization of this assay is an ongoing challenge. And then, of course, you often end up testing a lot of laboratories on these patients because many of them are going to get chemotherapy. The nasopharynx is basically kind of a cuboidal box shape. The anterior aspect is bounded by the choanae, or the opening to the nasal cavity. Superiorly is the quote-unquote clivus, which is a combination of the basosphenoid basa-occiput. Inferiorly, you'll have the soft palate boundary, and then posteriorly, the prevertebral fascia and cervical spine. Laterally is this sort of what I call hook-shaped structure, which we teach our residents to look for. It's the torus tubarius, and then behind that is the fossa Rosenmuller, where about 90% of these cancers will arise. And then, of course, Dr. Stambuk reviewed really beautifully the pharyngobasilar fascia, which is critical to this disease, and we'll talk about that in a second. I think about things very simply. So one of the things I first think about when I see a nasopharynx cancer patient is, is this patient going to have chemotherapy? Because that just means I'm going to have to do a lot more work to get that patient worked up and started on treatment. And so I think about sort of easy versus invasive patterns of spread, and the staging system reflects that. And it has gone back and forth since the 6th to the 7th edition, but essentially at this point it's settled down that basically if the cancer grows out into the airspace, meaning into the nasal cavity or the oropharyngeal airspace, it still counts as a T1. So a T1 basically means confined within the black areas or the air spaces, basically not invading into the parapharynx. And if you go out into the parapharyngeal space, then you get into T2 disease. It's been clarified now. There's no more T2B. It's just T2, T1, oropharynx nasal cavity, or nasopharynx proper, T2, parapharyngeal space, and T2 qualifies you for chemotherapy. And the importance of parapharyngeal space is somewhat historic. So in the past, parapharyngeal space indicated some predisposition not only to local regional recurrence, but also to distant recurrence, because you get access to the venous plexus when you go out into the parapharynx. But interestingly enough, recent IMRT series have looked at this pretty extensively, especially in China, and with the advent of IMRT, the local control for parapharyngeal has become very good. They still do remain at some increased risk overall, which is why they remain at T2, because this is reflecting the survival. And then when you get into T3, it's either involving the bone of the skull base or the paranasal sinuses, and then the T4s are the really bad ones. We see this a lot, however, because sometimes these cancers can be very aggressive, involving up to the skull base and intracranially, the cranial nerves, and as Dr. Stambuk showed us, the infratemporal fossa, and then going outwards into other really rare regions. I don't see this a lot, but they can go down into the hypopharynx, orbit, or masticator. So here's a beautiful example of a nasopharynx cancer that's being very respectful and not doing anything to the pharyngobasilar fascia. And you can actually see from that very sharp contrast line there exactly where that line rises and how there's thickening, but there isn't invasion through. But there is a defect in the pharyngobasilar fascia because things have to go through it. So you have the traversing of the eustachian tube and the levator-palatine muscle, and this becomes an access route back up to the parapharyngeal space in the base of skull. And the parapharyngeal space, just to remind everyone, is not the masticator space. It's a little bit more medial to it, and it lies just outside the mucosa of that lining there. And as you see here, this is a case where it really has gone parapharyngeal. If you look particularly at the second image there, you can see how it's gone way outside that boundary of that fascia and not quite into the masticator. And then if you go further, if you go up to T3 stage, this is a great example of bony invasion. You can actually even see it just on the CT scan here. When you look at that, you can see that erosion of that bone. And then if you look at the MRI, you actually see tumor extending back, almost touching the brainstem. And that would certainly count as T3. And in fact, this patient had T4 cancer because there was also intracranial invasion. And this is a different form of T4 invasion. So in this form of T4 invasion, it's an unusual situation. I haven't seen a lot of patients do this, but this patient actually had invasion so far laterally that it actually come out and invaded into the masticator. And so that very extensive lateral invasion also counts as T4. So one important thing about nasopharynx cancer is there's basically two kinds. There's the type 1, which is called keratinizing. And then the WHO has basically classified all the other ones as non-keratinizing. They used to be called type 1, 2, and 3, for those of you who remember, but they've switched it now to type 1 keratinizing, type 2 non-keratinizing, and then within type 2 there's differentiated or undifferentiated. And some people might remember even further back than all of that what we used to call lymphoepithelioma, which is essentially these very, very undifferentiated types of endemic cancers as well. Just a sort of more traditional name for it. There are other pathologies you can find in the nasopharynx, like lymphoma, melanoma, sarcomas, minor salivary gland tumors. I'm not going to talk too much about those. Those sort of belong more with Dr. Krause's lecture than mine, as we often treat those surgically. And the important thing about these two different types is that they're real survival differences and differences in natural behavior. We see this very dramatically at my institution, where we treat a lot of the endemic type, but when we get a non-endemic type, it's a very dramatically different behavior, and it clinically manifests in a way that you can see in your practice. And in North America, what you see is that a larger percentage are keratinizing, but still the large majority are going to be the endemic non-keratinizing type. But in southern China, there's almost no keratinizing type. They're almost all this non-keratinizing endemic type, up to 95 or even 98% if you count both of the type 2s. And the difference here manifests not only natural behavior, but survival. So a very old study I found from 1995 looked at the difference between keratinizing and non-keratinizing, and what they found was that the 5-year overall survival was actually very low for keratinizing type, and for the non-keratinizing type was actually around 50%. And where did this difference in survival come from? Because of primary tumor control. So while we can achieve great tumor control in these very chemo-responsive, radiation-responsive endemic types, type 2, type 1 keratinizing does not respond as well. And I will say there's been a recent updated series from the University of Michigan that looked at the influence of HPV. I know there's been a lot of excitement about the idea that some of the type 1 keratinizing might be associated with HPV. Still, the survival is not that much better. Even in type 1 keratinizing type, I think in Michigan they got about 20% survival at 2 years, and even with the HPV influence, it was still 30%. It was still about 20% lower than the endemic type. So it's an interesting difference in the ability to get tumor control. And then the other commentary here is that the type 2 or non-keratinizing endemic type has a much higher predisposition for nodal metastases and distant metastases, so that's where their late risk comes from. And you see this particularly in the patients that present with super high nodal disease burden. We see this a lot at my institution, especially some of these patients who are immigrants and don't have the greatest access to health care. They present pretty late. In general, nasopharynx cancers are very highly predisposed to spread to nodal metastases. Old dissection series show that you can get up to 90% subclinically node positive, but even just on clinical exam, up to 50% of them will be bilaterally node positive. And the type of cancer has an impact on this with, as I said, a slightly higher predisposition for the endemic type to go to lymph nodes. In fact, I don't know that I've probably seen in my entire career thus far, which is getting almost 10 years, two patients who were endemic type who did not have nodal metastases. All the other ones did. And the interesting thing, and what I find really frightening about patients with these high nodal burdens when we see them, this endemic type, is that 40% of them at presentation with N3 disease have metastases, and 75% of those patients will go on to have metastases. So it's a really clinically concerning issue when they have these very high nodal burdens. Just wanted to show an example of what that looks like, and to reemphasize the idea, because I see this all the time, there's a lot of confusion about how to stage the neck. Nasopharynx has its own distinct staging system, and the neck staging is different for nasopharynx cancer than it is for other squamous cancers of the head and neck. So we don't call this N2B or N2C, we call this N1 or N2. And this is a 28-year-old patient of mine I happen to be treating right now, EBV positive, Hong Kong extraction, but born in the United States, and she has bilateral nodal disease. That would be N2. Not N2C. In the nasopharynx world, we only have N2. Now, there is a change that's happening. I'm going to go through the end stage for a second, which is the 7th edition, and then I'm going to tell you about something sort of on the horizon. It's been published, so we can talk about it. It's not embargoed like the other staging changes. So end stage in the 7th edition in 2010 was basically this: single or multiple unilateral disease or retropharyngeal. Even if it's bilateral retropharyngeal disease, is all in one. If you get the bilateral disease, like we just saw in that patient, then you get to N2. And then they had a division of the N3 stage, which was any node that was really huge or a node that went into the supraclavicular fossa. And the supraclavicular fossa was defined by these 3 landmarks. This is a traditional clinical definition that was developed basically out of sort of necessity and invention at the time, basically using the 2 ends of the clavicle and the point where the neck meets the shoulder. And this is how we've defined the N3B stage in nasopharynx cancer up till now. And of course, it includes the caudal portions of level 4 and 5B, which is very confusing in terms of how you discuss this with a radiologist. Because it's a clinical definition as opposed to a radiologic definition. So this is an example of a patient of mine. He actually just finished on protocol, 55-year-old Filipino gentleman, EBV positive, and as you can see, he has unilateral disease, but unfortunately, he doesn't get N1 stage because he has disease that extends all the way down very far, and it is somewhat rare to see this, but he has disease that actually extends quite far into the true supraclav fossa, clearly below the point where the neck meets the shoulder. So by the old definition, he's N3. And the other thing I want to point out is that we see some weird presentations at my institution, and one thing that I see sometimes, which is not defined in the staging system, but I think is interesting, is parotid backup. There is communication between the nasopharynx and the parotid, and you can get lymph node metastases to the parotid. There's an interesting paper, again, that Avi Eisbruck published a long time ago looking at this, and you really only see this, and I agree with his clinical observation, that you only really see this when you have massive backup in level 2. That's when I've seen it sort of manifest with parotid involvement as well, and this is a patient who obviously has both of those characteristics. So the stage grouping in the 7th edition in 2010 was basically, like I said, they dropped out the separation of the T2 category into T2A and T2B, and it was just T2 for parapharyngeal, and then sort of more traditional groupings depending on that. And as you can see, because of the T4 and N3, we had stage 4A and 4B. That is has been used for a while now in clinical trials, and essentially anyone with T2 parapharyngeal involvement or with nodal disease of any kind is basically eligible for concurrent chemoradiation on current protocols. Now, what's going to happen to this in the next edition of the staging manual? There is a proposal out there, which I believe has quite a bit of interest behind it. This was based on a review of 1,600 nasopharynx patients treated in China and Hong Kong. And what they found was that there were no survival differences in patients who had involvement of the medial and lateral pterygoid muscles, the prevertebral muscles, and the parapharyngeal space involvement. So all of those patients have now become defined to be T2, which is interesting because you don't necessarily think about pterygoids quite that way with other squamous cell cancers of the head and neck. And furthermore, the confusion about the low node levels they're attempting to resolve that. They used to call it the supraclav fossa. It will now be called the low neck that begins at the caudal edge of the cricoid. They will be combining them all into one N3 category. There is no longer an N3A and an N3B. And they will all be called stage 4A, as opposed to the 4B category, which used to be N3 is gone, and it's all 4A because the survivals were found to be the same. So this hasn't been approved. It's just been published as a major proposal, but some of the people who are on the publication are pretty influential within the staging of the AGC, UICC, and I'd be surprised if those wasn't taken very seriously. So this is an example of the change. So the 7th edition, as you see, is in the blue and the yellow there, and then the proposed 8th edition would expand that to include the pterygoids and the prevertebral fascia. And then as you see here on the other side there is the diagram showing the low neck, which basically now would encompass below the cricoid margin, the true level 4. And there will be no more clinical definition of low nodes. So nasopharynx cancer, in my experience, almost always goes to bone when it metastasizes, but it can go to liver, lung, and mediastinal nodes. And the only reason I put this in here was that there were a couple recent publications this year looking at breakdown by metastatic prognosis. And I just wanted to mention that there are patients with oligometastatic disease who can be cured with very aggressive combinations of chemotherapy and focused radiation. There was, in fact, a pediatric protocol that did that and was fairly successful. And furthermore, that there may be different prognosis and that isolated bone or lung lesions are better in some cases. So the treatment modalities. Now we're going to leave some of the anatomy behind and move to treatment. Radiation therapy is the backbone of nasopharynx cancer treatment, which is why I love this disease. And chemotherapy is often given concurrently. We usually reserve neck dissection or salvaged nasopharyngectomy for true failures, but we would not usually start with surgery. And part of the reason for that is what I talked about, which is that there's a very high level of nodal spread in this disease. And you know, it's probably a good strategy up front to electively treat as a very extensive level of the neck if you can. And furthermore, operating in the nasopharynx can be really challenging, and getting clear margins in the nasopharynx is not always an easy matter. So there's some issues why radiations become sort of the core of the treatment. Although there are special cases, I'll say, where we have used both nasopharyngectomy and neck dissection to good extent. The reason why chemoradiation became established is this very classic trial, which many people call the ALSARAF trial. It was an intergroup trial, and basically it was a randomization between radiation alone and radiation with cisplatin, followed by adjuvant cisplatin. So adjuvant cisplatin was built into the program here with 5FU, and it's important to remember that these were conventional fields, so opposed lateral fields, that this trial was run in the United States, where there is not as much experience with nasopharynx cancer, and certainly with designing nasopharynx cancer fields. But as you can see, the survival was so dramatically different that the trial closed early. There was a question about whether the histology had influenced that, and maybe this was a unique thing because U.S. cancers were so much worse prognosis and they benefited from chemo. But these trials in the Asia confirmed that that was actually the same finding that they were getting. The toxicity was clearly higher, that you pay a significant price for the chemotherapy being added concurrently. This is a follow-up study that was run through the RTOG, now NRG, an IMRT feasibility study, in establishing that T2, what's now T2, alone, not T2B, but T2 or N-positive disease would be treated with IMRT, and I wanted to show this to show how the uniqueness of IMRT for nasopharynx cancer is the ability to make this horseshoe-shaped distribution, which allows you to treat around the spinal cord and brainstem in ways that conventional fields really do not. And this accounts in a large part for the improved local regional control that we saw in 225 and in many retrospective supporting series. Now, the last thing I want to talk about is the evidence for adjuvant chemotherapy. I see my time's running down here, but basically the evidence is pretty weak. This is a reanalysis of a trial from Hong Kong where they tried to show that the dose of adjuvant 5FU had an effect on distant metastases, but that has really been thrown into question with the publication a few years ago of the Sun Yat-sen trial, a large trial looking at 66 gray with or without weekly cisplatin. The curves were nearly identical at short follow-up, which resulted in a downgrading from the NCCN, whereas this had previously been a Category 1 recommendation as a complete package. It's now considered a Category 2A or 2B. And there are many controversies about this, primarily focusing on the fact that there was high dropout from all chemotherapy, even weekly, that there was short follow-up, and questions about the follow-up. There's been 2 induction trials that failed to show advantages, and as a result now, I'm just going to skip to the end here, we're now looking at a way to more intelligently design adjuvant chemotherapy, and the hope is to use EBV as a biomarker. So this is an important study from the New England Journal of Medicine showing that the EBV biomarker within a week after radiation completion basically decides your prognosis. If your EBV is detectable, you can see that that line sinks down to very low ranges. And this is the current study now, which I'm going to end with, 001, which is basically based on a reassessment of EBV DNA at the end of chemoradiation. If you are detectable, you go into an intensified chemoradiation randomization. If you have undetectable EBV, you actually have the chance to avoid chemotherapy versus the standard of care. So I think this is going to be an important platform going forward, and the important part about this is that the NRG has now established EBV DNA as an international platform that can be used by other investigators for future trials in this disease. Thank you.